Thank you very much for the introduction. I was really very honored to receive that invitation. I'm really impressed by the kind of work that the initiative is doing with salivary gland cancer. So my deepest respects to that and what you've already achieved. So I was working at the University of Heidelberg for quite a while during the time when they started their carbon ion project. And that's the reason basically that I would like to give you a quick summary about how the pilot project came to be and how further developments actually came to be from a German carbon ion perspective. So I hope I can share those slides. Let me just check. Okay, all right. Okay, so let's get into it. So I'll just briefly introduce you to the basic problems that we have when treating salivary gland tumors at the base of skull and especially also at the paranasal sinuses, the rationale for introducing particle therapy with that specific indication, some of the specs, especially in carbon ions, and basically how the carbon ion project developed throughout the last, let's say, 20 years. Okay, right. So what we can see here is an MRI slice of a patient with sphenoid sinus adenocarcinoma. So what we see here is this large mass in the sphenoid sinus, also attaching to the maxillary sinuses on both sides. And our problem really is obviously the healthy brain tissue, the brainstem, arteries, but also when you're looking at the coronal slice here, the optic apparatus as well. Those are structures that don't tolerate high radiation doses very well. But we also know that, especially for salivary gland cancers, we do have to use high doses to generate a long-term local control. It's also problematic because, especially in those rare cancers, we don't have very many comparative data. So at the time when the idea of carbon ions came up, what we were working with was the rationale of the physical properties that we could exploit in carbon ions, but I'm getting to that a little later. Obviously, you are aware that this is a rare cancer type. Incidence is about 1.3 in 100,000 per year, and the most common histologies are mucoepidermoid carcinoma and adenoid cystic carcinoma. Quite early, there were initial investigations regarding neutron radiotherapy, and that has started as early as the 50s, but the most commonly known was the MRC trial here that was carried out in the UK in the 80s. And what they could basically show was that the local failure rate here on that graph on the left-hand side, you can see here the follow-up time. This is the local failure rate. And when you're looking at photons compared to neutrons at the time, the local failure rate in those patients included in neutrons was much lower than the local failure rate with photons. Now, bear in mind, that was a time when there was virtually no CT-based planning because CT was just invented and wasn't used for radiotherapy planning at the time. So that was a very basic dose calculation and dose application at the time. When you're looking at the overall survival of that patient cohort, we didn't see significant differences between photons and neutrons. We're looking at those follow-up. And what we did also see was that patients treated with neutrons experienced quite marked late effects, like late side effects. For example, fibrosis was a big problem at the time, and also bleeding complications. Further data that our colleagues in South Africa published a few years ago could demonstrate that with especially adenoid cystic carcinoma, and those were very advanced adenoid cystic carcinoma patients, we can still create high local control rates. Here, this is local control, no longer local failure. With regards to the median follow-up and the median local control, we were here at about 60 months. So that was still a promising approach, and that showed the radiotherapy community that high doses and higher biological effectiveness might have an influence on local control and will have an influence on local control in salivary gland cancer. So that idea prompted further research. what we do know, especially with the example of neutron radiotherapy, is that we operate in a very narrow window of opportunity. So when you're looking at this qualitative graph as early as 1933, we found out that we can increase tumor control by increasing radiation doses. That's the green curve. But unfortunately, in parallel to that, and that's the red curve, we also increase complication rates. And we do operate in this narrow window, narrow therapeutic window, to treat our patients with minimum or even moderate complication rates to a significant tumor control. Now, the question really is, how can we broaden that therapeutic window? And obviously, in order to broaden this window, it should be possible to bring complication rates down and shift that curve to higher doses. And you can do that by applying radiation more precisely and excluding most of the healthy radiation, most of the healthy normal tissue. And the way to do that, and that's what happened all over radiation oncology, was by employing more and more precise methods. So stereotactic radiotherapy was one method. Intensity modulated radiotherapy was another method that became available by the end of the 90s. And at the same time, also charged particle therapy was available or became available for radiotherapy. And when you're looking at this graph here, that's basically the rationale why we would like to apply particle therapy when we would like to spare healthy tissue. When you're looking at the blue curve, this is the depth dose distribution of standard photon radiotherapy. So when you're talking about radiotherapy, normal radiotherapy, this is the type of radiation that you would use. And when you're looking at this is the depth in water or even the depth in tissue, where this is the entrance and this is the path of the radiation or the particle. And you can see with standard radiotherapy here on the blue curve, usually the maximum dose is deposited about 2 to 4 centimeters depth. When you're looking at carbon ions or protons, carbon ions, the orange line, protons, the blue line, you can see that we distribute most of the dose at the end of the path of the particle. So what we usually do is we choose the penetration depth by giving the particle a specific energy. If the particle has a lower energy, the penetration depth will be lower. If it has a higher energy, the penetration depth will be higher. So depending on the particle energy, which is basically dependent on the particle's velocity within the accelerator, you can then reach either deeper or more superficial targets. Okay? And the good thing basically by using charged particle therapy is that the particles lose all of their energy at the end of their path. So they actually stop, which doesn't happen with photons, right? That is usually the reason, for example, photons, that you can never stop them, that you can actually make X-rays, that you can create images at the other side of the body when you apply the beam. That wouldn't be possible for charged particle therapy because those particles lose all of their energy at their end of the path. And that creates very steep dose gradients that you could use medically. However, there's some caveat to that. When you're looking at a standard wave, like even water, okay? And you compare that to this Bragg peak, to the shape that we use for a path of a particle. You would also have to be aware that this curve has other dimensions as well. Oops, sorry. And not just in that direction, the direction that I've shown here, but also in the width as well. And there are differences between protons and carbon ions, as you can see here. So this would be the direction for the Bragg peak, and that would be the width of the beam. And when you're looking at that dimension, there's differences between protons, helium ions, for example, as another charged particle, and carbon ions. And we can create the steepest gradients in the width with carbon ions as opposed to protons. So there's one benefit, and that would be the penumbra, the width of the beam. Is that understandable? If it's not understandable, please let me know and I can try to explain. Yeah, it's beneficial, especially in those challenging locations, as I've shown in the beginning, especially on the base of the skull, right? Where you've got those tumors mostly very directly adjacent to critical organs. And those organs usually tolerate less dose than you need to control those tumors. Just as an example, when we try and apply standard radiotherapy doses to adenoid cystic carcinomas, usually we were looking for more than 70 gray, better 80 gray within the center of the tumor. And if you've got the optic system just adjacent to that, that also means that most of that dose goes through the optic system. Now, the optic system only tolerates 54 gray at a max, right? And so that basically means that you could either limit your radiation area to, and then leave parts of the tumor untreated, or that you would extend the dose to the optic system, basically generating this patient visual loss at least at one side for those patients, right? So if you can generate very steep gradients, that area where you would have overlap of those structures or of dose to the other structure would be smaller. So very steep gradients at those areas are very beneficial. Is that logical?
Yes, definitely. Thank you.
All right. Okay. So, and basically to a steep gradients, there's various dimensions. So there's the longitudinal dimension, which I told you with the penetration depth, but there's also the width of the beam as well. And this is what we're talking about here, the so-called penumbra, the beam breadth. And that will be the steepest gradient in carbon ions as opposed to other charged particles. Okay. Right. There's the other part of charged particle therapy of carbon ions, especially in that's biological properties. So when we're looking at a cell nucleus here, and we just imagine we treat those nuclei with photons or protons, that would be the upper image, or with carbon ions at the same physical dose, that would be the lower image, we can see differences in DNA damages. So when you were looking at the DNA level, both photons and protons generate simple DNA lesions. And those lesions can usually be repaired, at least in normal cells, quite well. Tumor cells have repaired deficiencies, but still they can repair single-strand breaks or just a few double-strand breaks more easily. When you're looking at the damage patterns of carbon ions, those are usually more complex, and those are not very easily repaired. And that basically leads to the difference in relative biological effectiveness. So when you're treating, here in this example, tumor cells to 2 gray photons, that would be the black line, as opposed to 2 gray carbon ions, you can see, you can see a difference in cell survival between those two radiation patterns, right? And that basically is expressed by this more complex DNA damage pattern in carbon ions as opposed to photons. So by applying the same physical dose, 2 gray, for example, we generate much more damage with carbon ions than with protons or photons. Okay. And that's also something, the way that those damages are generated, that can be useful for certain tumor types. Now that idea is very old. So the physical properties of charged particles and the biological properties of those particles, they have been recognized quite early. It wasn't very easy to make those useful, unfortunately. So that took a while, also by generating new ways of applying the beam, physical, like technical properties to apply the beam. But also we needed a way to be able to plan. And as I said, like CT-based treatment planning was only available by the mid-90s. and also CT MRI fusion, those techniques that developed by the end of the 90s, beginning of the 2000s, and being able to generate dose distributions from that. So that is not very old, right? And so the first ones to actually apply carbon ions to patients with head and neck cancers in a more modern way with CT-based planning were the colleagues from Japan. And as you can see here, they had quite advanced patients with adenoid cystic carcinoma, and they were able to generate impressive local control rates as opposed to standard photon data at the time with carbon ions. Right. So basically, we found out that we can translate those ideas, the physical properties and the biological properties, into clinical benefits. So roughly around that time, the German carbon ion pilot project came to be. So the first proposal based on the Neutron data was made by the end of the 90s, and that wasn't successful, so it wasn't granted. Then beginning of the 90s, they started applying as a European consortium. Also, that wasn't deemed successful at the time. And then the scientists at the GSI, that was a basic research facility. They do astrophysics, high energy physics, things like that. That isn't a medical research facility at all, but they were dealing with charged particle acceleration for various other reasons. And they developed intensity controlled raster scanning, which is a very precise way of applying charged particles. And I'll show you that in a minute. And it didn't take long after four partners, like four research institutions, partnered up to start the pilot project on ion beam therapy at the time. And that was the GSI, the Society for Heavy Ion Research at Darmstadt, which is about half an hour south of Frankfurt. The German Cancer Research Center at Heidelberg, the University Hospital Heidelberg, and the research facility Dresden-Rossendorf, which is also a basic science institution. So only the German Cancer Research Center and the University Hospital at Heidelberg were basically medical or even part medical facilities that contributed, whereas the rest were basic science facilities. So only 3 years later, the first patient was treated with carbon ions at the GSI at Darmstadt, and I'll show you that in a second. So first of all, concerning intensity-controlled raster scanning. So what they basically do is that they cut the tumor into several slices, and then they treat the tumor slice by slice. Okay, and this is what you can see here. This is the tumor that they've virtually sliced. And unfortunately, that should run. Sorry. So that should work now. So one slice at a time, and then they apply all of those Bragg peaks next to each other, all of those steep gradients, and they treat that tumor slice by slice. And that generates also very precise dose applications. Before, what was usually done at the, for example, older proton facilities was they were producing a beam with just one energy. And as we've just seen, that would generate just one penetration depth. So in order to be able to treat a whole tumor, which obviously has a certain dimensions, they would have to use compensators in front of the beam, and that generates various difficulties. So in order to be more precise, you would have to apply the radiation treatment spot by spot. And this is what you've just seen on that movie here. This is the facility at Darmstadt, which you can see here, that is no medical facility at all. It's basic science, right? And at the time, we were allowed at one part of this huge facility, which was just here. And that was the medical cave where we were allowed to treat patients 3 times a year for each 20 days, right? And obviously the facility itself didn't look like a hospital or standard radiotherapy facility at all. You can also realize at the time we were still using Scotch cast masks to immobilize the patient very rigidly, because we wanted to make sure when we apply a very precise beam, then the patient position has to be very precise as well. So that's why we combined the precise dose application with a very rigid immobilization of the patient. And then to be able to control the position, we had the X-ray system. That was, when you're looking at the right-hand side, you could just move that one down to the patient before the treatment. This here was the beam line where the beam basically was applied from. And then we had a PET scanner to be able to check whether the position of the beam application was actually accurate. The reason why that is actually working is that carbon ions at the end of their path generate some radioactive nuclei with a very short half-life. And those emit positrons, and those positrons can be detected by a PET camera, and then you can verify that you've actually applied your beam correctly. Okay, so there were two types of verification. So the prior verification, as you know from each radiotherapy, you check the patient's position. If you're happy with the position, you apply the beam. And then there's a second check that actually the beam was applied at the correct point. Okay, so all of that basically end of the 90s. So technology also with those components changed. But at the time, we were the only particle therapy institution in Germany. So our patients came from all over Germany and from adjacent countries, some from Austria, some from France, some from Poland, I think here, and some from the Netherlands and Benelux countries. All in all, we included about 63 patients with adenoid cystic carcinoma. Most of the patients actually had chondrosarcoma and some chordoma patients. And when we were looking at the patients with adenoid cystic carcinoma, obviously all of those patients were advanced patients. So all of those patients, most of those patients were T4, some T3 tumors. Most of those patients in the paranasal sinuses or the base of the skull. And patients that presented at the time when they could receive carbon ions were offered carbon ion treatment. Okay, so as I said, we only had the chance to treat 3 times in a year for 20 days. So patients that presented at those times received the carbon ions, and patients that presented outside of those treatment slots received standard IMRT treatment at the time. Luckily, our baseline characteristics were almost comparable, right? So also most of those patients with IMRT had tumors at the paranasal sinuses or the base of the skull. So we were actually quite confident that we can compare those two groups reasonably well. But to be honest, it wasn't a prospective randomized trial, right? We're comparing 2 sets of patients that weren't allocated randomly towards their treatment. Now, when my colleague Daniela Schulz-Erdner published those experiences the first time, which was 2005, we could already see that local control in patients with carbon ions seemed to be better than local control in patients who received photons only. At the time, due to those low patient numbers, 2005, that wasn't significant. And we also saw that it wasn't significant, there was no significant difference in overall survival in those patients. Now, that judgment completely changed when we did the update in 2015. So when we were looking at those data, patients with carbon ions here exhibited a significantly improved local regional control as compared to standard photon radiotherapy. And that apparently translated in an improved overall survival here on the right-hand side for those patients with carbon ions as well. And that is the basis why, at least in the areas where carbon ions are available, usually those patients are offered carbon ions, at least within the German health system. So based on those data, and we had similar promising data for chordoma and chondrosarcoma as well, which are the most common indications that we treated within the pilot project, the Heidelberg Ion Beam Center was projected. So also quite early after the first 5 years of the treatment, we already had some indications that this might be a successful and promising option for patients. And then they projected the hospital-based carbon ion facility at Heidelberg like this. So that was the layout of that is the layout of the facility. So at the time they had 2 ion sources available. One was protons, one was carbon ions. You could choose between them, and the switch is instant. So you could treat patients in one room with protons and switch to carbon ions in the next room. So that is not a problem. That doesn't take long. You just ask the accelerator to provide it, and the switch really is instant. So there's a huge synchrotron, and I'll show you a few other pictures of the dimensions of that facility. There's 2 treatment rooms with a horizontal beam line where the beam line is fixed on the wall, and I'll show you some images. And there's one other treatment room with a carbon ion gantry. Now that gantry at the time was the first carbon ion gantry worldwide. And due to the problems with directing carbon ion beams and what has to be considered by directing those beams, that was a major event to be able to generate a carbon ion gantry. So this is one image of the accelerator room, and what you can see here is the beam line. So that small structure here, that would be the beam line. The yellow structures here, they are the focusing magnets. And the red structure here is a bending magnets to keep those particles on the track while they're accelerated, and the yellow ones to focus the particle beam and keep it sharp, right? And in between there's vacuum pumps, because obviously you would not be able to accelerate particles to such a high velocity in normal air. You would really have to have a very high vacuum to be able to do that. Okay, and that's a close-up look of the beam line here with the focusing magnets and with the bending magnets, and in between with the vacuum pumps. So that is the structure of the Heidelberg Gantry. And as you can see here, with a weight of 600 tons, that is a major structure to put into one place. And the treatment room itself would be just this part of the gantry, just this part. And the rest is just serving one purpose, to focus and to move the beam to where it actually should be. This is the way it looks inside the gantry. So you can see here one of my colleagues positioning a patient on the treatment table. The beam exit would be here. And we would have orthogonal X-rays here. So when in treatment position, the floor would just give way. So the whole structure can basically turn to 360 degrees. That was the startup team at the time. So it took quite a diverse team of medical physicists, engineers, doctors, quality management people, also administrative people to get that facility up and running. So that was a very exciting time between 2005 and 2010. We started up the facility and the gantry system. And the Marburg Ion Therapy Center, which is very close to where I work right now, has a similar layout. So this is basically a sister facility, also with 2 ion sources, 3 horizontal treatment rooms, and 1 45-degree treatment room. So that facility does not have a gantry. Right, in terms of clinical data, how can we support the idea that we would like to treat patients, especially advanced salivary gland patients, with carbon ions? So based on our first experience, we obviously established further protocols to improve the treatment. And what we saw in the data that I just shown you is that obviously we could not control all of those patients. So some of those patients unfortunately developed further tumor progression within the radiation field. So when they did that, they still developed that progression within the high dose area. So even the area that got carbon ions couldn't be completely controlled. So the idea basically was, when we established the COSMIC trial, to increase the carbon ion dose part, and see whether that could improve the outcome. So at the time, Heidelberg facility was up and running, so we started 2010. And we had a very well-functioning cooperation also with our Italian colleagues, mostly with the ones at Brescia and at Milan. At the time, in Italy, there was a high political pressure also to establish particle therapy with protons as well as carbon ions for Italian patients. So those cooperations also served as a basis to show that it's feasible and those patients profit from their treatment. So that basically led to the fact that we could complete the trial, or could complete accrual to the trial within 1 year. So we accrued 54 patients within 1 year of opening that trial, and had quite promising results at the time that I did the evaluation in 2015. So they may actually do the update on those data right now, but that hasn't been published so far. So what we can see here is that with a larger patient number treated with carbon ions, we can still achieve the same results as in the pilot project. And we have also quite promising results in terms of local regional control, right? So when we were looking at operable versus inoperable patients, we could not see a significant difference in that cohort. So that is also another promising approach, especially when looking at very advanced tumor stages. So when we did the update on all the patients that we treated in and outside the clinical trials, we can look back at about 309 patients with adenoid cystic carcinoma treated within the pilot project and within the routine at Heidelberg, and still we can maintain the local regional control that we initially saw in the pilot project. When we were looking at local control according to whether or not a complete resection was possible or nearly complete resection was possible, we didn't see any significant differences yet. However, when you're looking at those patients that we included with microscopic residues, and those were not included in the pilot project, they seem to be slightly better off here on those graphs. The follow-up for those patients was at the time quite short, so it's very hard to make a definitive conclusion about that. And so the update that they are doing currently will be very interesting to see how that curve is continuing. Again, as I was mentioning before, I really wonder how to treat those patients with extremely large tumors, especially at the base of the skull. And then when we were looking at the data and comparing toxicities of those patients, we saw that patients that were operated extensively, as opposed to patients who were not extensively operated, then toxicity in those extensively operated patients was much higher than toxicity in patients that were not as extensively operated. And the reason basically is, when you're looking at the MRI scan that I've shown here, that is a pre-operative MRI scan of the patients that we treated post-operatively. So pre-operatively, we would have treated this area encompassed by the yellow line, right? When you're looking at the post-operative situation, obviously due to those changes in the surrounding tissue, we would have to treat a much larger area that would be encompassed by the red line. And when we were looking at all of those patients who had received extensive surgery, we could see that the radiation field increased 2 to 8-fold by doing extensive surgery. And that basically is the reason, if you're treating a larger area, then obviously side effects will be higher. And that is only worth it, obviously, if we can achieve a higher local regional control for those patients. Now for the T4 tumors, which is a very extensive tumor stage with the tumor invading adjacent structures, that does not seem to be the case. So that would be one thing that we would have to look into further, where we have actually a very promising indication that we would no longer need huge and really extensive surgery in those situations. The case is different for smaller tumors, obviously. So if if you can do a resection with less morbidity, then that's not a problem, right? But especially for those patients who suffer from the surgery, from extensive surgery, that would be an option to say, right, I mean, with high dose radiotherapy, we may not have to do that extensive surgery. And this is one of those examples, a patient who had extensive surgery and still had macroscopic tumor at the edges. And if you're looking at the patient, he really suffered cosmetically from his surgery and may potentially have benefited from a straightforward radiotherapy at the time. So looking at the 309 patients from the 15 years experience, we can support that idea. But the other thing that really worries us in salivary gland cancer is that they can generate late occurring metastases. So when we're looking at what Christer Hart published 20 years ago, he could already show that tumors that are very small do not have such a high risk of developing distant metastases, but the larger the tumor is, the higher the risk is that there might be distant metastatic spread. And when we're looking at the years following initial diagnosis, we see that especially in salivary gland malignancies, metastases can occur, like even first metastasis can occur even beyond 10 years following initial diagnosis. Most of those metastases appear in the lungs, some in the liver, but really most commonly the lung is affected by distant metastasis if that occurs. So the idea really is, can we do something against those distant spread as early as in the initial treatment? And that was why we approached a combined modality treatment with, at the time, cetuximab was a very promising drug, not only in adenoid cystic carcinoma, but for various other tumor types as well. So we combined the initial pilot project concept with additional cetuximab given in weekly doses. And what we did see was that we could see very early remissions of those tumors. So here is a patient with a large mass on the maxillary sinus on the left side, invading the main nasal hole, also the pterygoid muscles here, the chewing muscles. And you can see here on the coronal size, the longitudinal extents, which would be about 7 to 8 centimeters. So most of the time we see in standard radiotherapy and also carbon-iodine radiotherapy that it takes months until those tumors achieve complete remission. For the patients who have received cetuximab in the evaluation that we've done, we noticed that that might be a bit faster when also using cetuximab. So this is 6 weeks post-radiotherapy, and you can really see that there's hardly any traces of this huge tumor left. Unfortunately, recruitment didn't really work as well as in the initial trial. So the trial took about 5 years to recruit 23 patients. And I'm still not sure why that was actually the case. So all we can say is that local relapse is actually very promising. But overall disease-free survival still needs to be further explored, because obviously 23 patients isn't huge as a number. Okay, local relapse following initial radiotherapy. And I'm just going to show you one example of a patient that was sent to us from our Italian colleagues with a huge mass here. And also extending into the ethmoid sinus, so that patient suffered from pain and also from compression of the facial structures, and had also undergone already any kind of systemic treatment that was available at the time. So we decided to do treatment for that patient with re-irradiation, and the treatment field was actually quite huge. There was more than 500 milliliters being retreated. The patient had received initial radiotherapy so far. And what we did achieve here in the comparison, that was pre-radiotherapy and that is post-radiotherapy, is a massive reduction of those tumor masses. So we didn't achieve a complete remission for that patient. So, but we did achieve that the patient was symptom-free, and that he had a good quality of life following the re-irradiation. When we were looking at all of those patients that I treated with re-irradiation, we see that response rates are actually quite high. So it is possible to achieve a good local response and good palliation for those patients at a very moderate toxicity. So there were 2 patients that developed tumor necrosis at the time, which means tissue damage, and that also led to bleeding in one patient. Bleeding in 2 patients, but that could be controlled. So there seems to be a limit to the dose that you could give in total. But the toxicity that we were generating with this type of treatment is still quite moderate. And when we were looking at the local control that we achieved here, we can see that we achieve a median local control of around 20 months with the way that we treated so far. So apparently, many of those patients will still develop further tumor growth, even following re-irradiation. However, that is a very promising approach, maybe combined with other modalities, maybe also combined with more increased dose escalation. And that is currently the approach that the Heidelberg people are looking into with a prospective trial. Okay, cost effectiveness is a big topic, but I'm running out of time, unfortunately, so we're not going to cover that in detail. Particle therapy in Europe is available in many places right now. So the UK has 3 or even 4 facilities for protons right now, and more facilities in Europe are opening. So there's even, I think, 10 new facilities projected in Spain, as I've just heard on the European meeting. There's 4 facilities in Europe that can offer both protons and carbon ions. And I'm just going to show you how to contact those facilities. So one of those facilities is Heidelberg, which I've talked most about. The other facility would be Marburg. Then there's the carbon ion facility at Knau, which is Pavia, about half an hour south of Milan. And there's Mid-Austron in Wiener Neustadt, which would be about an hour southeast of Vienna. So those are the facilities that can offer currently both protons and carbon ions. All of those, and I just checked this morning, offer consultations, and all of those offer some way of submitting patient information to ask whether treatment would be feasible for a specific case. So most of those also have at least English submission systems, or at least English websites that can be contacted. Does it always have to be carbon ions? Not necessarily. So most of what I just told you is a dose effect. So if you apply high doses, you will get a higher or an improved result. So most treatment planning systems also account for the differences in the RBE, as I've just shown you that carbon ions have a higher biological effectiveness, and that effect is already taken account of when we do the treatment plan. So treatment plans would be comparable between protons as well as carbon ions, and it all comes down to dose escalation, right? Steep dose gradients can be achieved both by protons, carbon ions, helium, oxygen, whatever is on the table right now. However, standard photon radiotherapy has made progress as well, especially with image guidance during radiotherapy. There's ways of being more precise with photons as well. If you're looking at MR-Linacs, for example, or if you're looking at the new options of adaptive radiotherapy, which is more advanced than what we can use in particle radiotherapy, adaptive radiotherapy so far. So the future will show, and hopefully those carbon ion institutions and proton institutions will cooperate to develop clinical protocols for specific tumor types, and then find out whether you basically need protons or carbon ions, or what situation would be beneficial for this specific treatment type. So far, if I can summarize the benefit that we achieve from particle therapy, it would be dose escalation next to critical organs because of those steep dose gradients. And that, in my view, is the primary rationale for applying particle therapy in salivary gland malignancies. Okay, unfortunately, I was running a little late, but I'm happy to take any questions you might have. It depends on the protocol. So that is usually the Heidelberg protocol, to have IMRT and the carbon ion boost for various reasons. The Knauer protocol would be carbon ions only, and the Med-Austron protocol, I think, currently would be carbon ions only as well. So that basically depends on the history of those facilities, right? Our history, the Heidelberg and also Marburg facility history, is based on the GSI experience. And when you remember that we had those 3 treatment slots per year, right, with each 20 days, we would not have been able to apply sufficient dose just by carbon ions to those patients with salivary glands. So there had to be some sort of trade-off, some sort of boost concept with photons and carbon ions. We continued that even in the period that we have the Heidelberg Ion Beam Therapy Center, because that also allowed a more stable beam application as well. When you're looking at the paranasal sinuses, there's lots of different tissue types next to each other. So there's air, there's bone, there's soft tissue, and those differences, they make problems also when you apply just carbon ions, because of those range uncertainties that you encounter when there's just minimal differences in patient positioning. So if you want to have a very robust treatment application, at least that was our view at the time, then the combination of both photons and carbon ions yielded a more robust plan. There's ways to take account of that now. So also the Heidelberg people approach a carbon ion only treatment, but they are just about to compare that with each other. That is a big problem, at least in the German health system. I'm aware that the UK system usually asks for phase 3 trials with randomization between photons and whatever protons or carbon ions. The thing is, our health system approved the carbon ions as a promising treatment in 2005 following the initial publication. And since then, most of the patients, at least in the regular health insurance, they are actually entitled to receive carbon ions. That is a German specialty, and that has other problems as well. So, but based on that, it is not really possible to include patients against a photon radiotherapy treatment, right? Because we already assume that the carbon ions in certain situations, and that's very advanced tumors, due to the physical properties, might be more beneficial than photons. So at least in Germany, I would not be able to include or to conduct a trial, just randomization, IMRT versus carbon ion. So that would no longer be possible. It's a bit like the discussion that we had when we were introducing IMRT, right? So that got adopted very early in the early 2000s, end of the 90s, when it became available. So first patient treated with IMRT was 97. And then usually adopted across larger institutions, it was around 2000, right? And we had the same discussion then. So basically, they still asked for head-to-head comparisons with standard radiotherapy, so no IMRT treatment. And that was really difficult to obtain. The UK was quite early conducting that trial. So when you remember Chris Nutting, he published the passport trial, including patients from 2003. So at the time, it was still possible. It was still in the early days of IMRT to randomize patients between those two treatment arms. But now, as you're saying, 15 years into carbon ion treatment, that will be very difficult in Germany, at least. I think what the UK trials currently do is to try and see whether in squamous cell head and neck cancer, protons are superior to photons. And that question has never been addressed before. So there's three centers actually. So there's Aarhus, Groningen, and the UK addressing those questions, whether protons should be routinely used for squamous cell carcinoma of the head and neck in terms of sparing the parotids, the swallowing structures. And that is a very important study to do. But that has another approach than salivary gland cancer, also in dose. Right, so what we're looking at in squamous cell carcinoma is around 70 gray. For salivary gland, what we applied in the protocols would be around 80 gray biologically effectively, right? So that's 10 gray more. So that comparison of around 70 gray will not really correspond to what we usually do for the salivary gland cancers. I really want to avoid the impression that carbon ion are the only ones that can cure salivary gland cancer, which is not the case. I mean, it really depends on the extent of the tumor that you're looking at. I mean, most of the patients really are treated in early stages, like some T1, then you don't even need radiotherapy. T2 is questionable, and T3, yes, maybe you should have adjuvant radiotherapy. And maybe, depending on the site, it really is not necessary to have carbon ions or protons for those kind of treatments, right? It becomes very interesting when you've got those anatomical challenging sites, as in the example that I've shown. Then there could be a benefit by using a more precise treatment technique, right? Once a person develops another tumor growth within the radiation field, the decision whether or not radiotherapy is possible really depends on the amount of radiation that has already been applied to those critical structures, like the brainstem, the optic apparatus, and other structures, right? And then the amount of radiation that we can still give depends on the type of technique you can basically use. So usually I would be very hesitant to retreat patients within 1 year of their primary treatment, right? Mm-hmm. So usually I would like to see at least a certain stabilization of the treatment of the tumor by the treatment. And following 1 year, every other year you would gain extra dose that you can apply in a re-irradiation situation, because we know that tissue doesn't forget radiation, but there is some sort of repair mechanism, albeit they may be slow. So the longer the prior radiotherapy is ago, the better you can apply new radiation. Areas where there's targets in motion, they're really difficult to treat. They're difficult to treat for photons, but they're even more difficult to treat for particles. Because what you would have to make sure is that all of those structures are at the same place that you expect throughout the whole treatment, right? And that basically also means that you would have to go through both lung tissue and bony tissue to reach the tumor. If either of those is not in the place where you expect it, you can have either an overshoot or an undershoot, right? So that basically means your particle either flies too far or not far enough. So especially if the tumor is very close to the spine, and you worry about overshoot, that basically you might hit the spine that you don't really want to hit. And even with a very precise treatment, if you cannot apply it, if you cannot position the tumor as precisely as you wish, then that might even be detrimental, right? And you would have to use, if you would like to treat organs in motion, you would have to use some sort of motion mitigation. What we normally do for photons for standard radiotherapy would be gating. That basically means that you apply the beam only in certain cycles of your breathing, right? And the beam stops once you're getting outside those cycles of the breathing. Or you could use a certain breath-hold technique combined with a beam, but those treatment techniques combined with both protons and carbon ions are in their early days, because steering of the beam based on the breathing cycle just is a bit more complicated with particles than it is with photons, due to the delay that you usually encounter when you have to accelerate the particles first, right? So imagine you get the signal, right? The tumor is in the right breathing phase. So now you accelerate your particles. That takes a few seconds, and then you can actually start the treatment. And so there's always a few seconds delay. By that time, the breathing cycle has moved on, right? And that makes it very difficult to actually do that. It will be possible in the future, but currently this is still a major challenge for particle therapy. So basically that's why most of those particle centers will say that they won't treat it, right? Also, there's some facility-specific problems that might be that one might not be able to overcome. For example, both Heidelberg and Marburg cannot treat through the table. So when you're talking about a paraspinal tumor, usually would like to position the patients supine, right? And that basically means you would have to treat through the table. To my knowledge, in Heidelberg, that's not possible, at least not in the spinal area, right? And Knau might have the same problem. And at Marburg, they don't have a gantry, they can't do it, right? So that's the reasons why they might not be able to offer this type of treatment. For protons, that could be more easy, because most of the commercial sites, most of the commercial vendors of those facilities, they've developed tables that you could treat through. So proton facilities might be able to do that, but they still have the problem with the moving organs.